This PowerPoint presentation will be addressing the issue of pain management during labor. So why do people have pain when they're in labor? Well, several different things are going on. The tissue has periods where it's ischemic, especially during a contraction. The cervix is dilating and effacing, so there's actual tissue changes. There's a lot of pressure on the soft tissues within the pelvic structure. The fetus is pushing on all those structures, and if the fetus is in an abnormal position, that will make the pain worse. Perhaps the pelvic structure is not ideal, and that is contributing to the pain experience. Also, if labor's been going on for a long time, the woman may be very fatigued and not able to cope as well. As nurses and physicians, we do things to our patients, medical interventions, vag exams, internal monitoring, and all those things factor into their pain experience. Also, there are psychological factors that are going on. There may be social dynamics within the family. Maybe the woman has had a bad experience with a previous delivery or with a pain experience in the past. Maybe she's fearful. Maybe she doesn't have any information about the labor process, and all that contributes to her fear and anxiety and increases her pain. So, what's the goal of pain management? Well, obviously, we want to decrease the pain. In some situations, we may be able to completely erase it. But at the same time, we want to increase or at least maintain the uterine blood flow, make sure that the contractions don't space out or that they don't get less intense. We want to help the woman to relax and not to be tensed up. And we want their fear and anxiety to either go away or to be better controlled. So you probably know from first semester all about the gate control theory. You experience pain somewhere, in this case the uterus. There is a sensory neurons pick up the pain. They carry it via the spinal cord up to the brain. The brain sends the message back to that part of the body that you're in pain. So the goal is to help to try and diminish or stop that message going to the brain that says, hey, you're in pain. So obviously there are physical conditions during labor that are causing the pain. But at the same time, women are usually very anxious before they go into labor, especially first-time mothers, and their bodies are very tense. They're focusing on the pain, or perhaps they don't have enough distractions and they're bored. And overall, they feel a lot of stress coupled with the physical pain. So what sort of things can close the gate? Well, obviously, there's medication. There's counterstimulation like heat, massage, direct pressure on the back. There are ways to help provide for an environment that's very relaxing and restful, to encourage the woman to have positive emotions, tell her what a good job she's doing. And as the nurse and as a support person, you can work on distracting her or helping her to focus on something else besides her contractions. Before she gets to the hospital, there might be other things that she can do in the home, like watching TV, cooking, cleaning, going for a walk, talking on the phone, other things that could distract her. So what types of things can you do besides medication? Well, there's breathing, there's distraction, helping the woman to relax. When you're trying to help someone to relax, it's really good for you to look at them and assess what parts of their body are tensed up. Usually you see it in the shoulders, in the neck, and in the face, especially the forehead area. Some women might also grab someone's hand very tightly or a side rail very tightly. So what you're going to do is just very gently tell them to, okay, relax your forehead, relax your shoulders in a very calming, soothing way. Cutaneous stimulation, just gentle massaging of the back, or effleurage, where you or the patient could rub the abdomen, providing a sense of distraction. Maybe you want to use some type of mental stimulation, something that they have to concentrate on. So in some of the breathing techniques, you can have them to count. You could have them follow a specific pattern. You could use visualization, trying to create them being in a different place, different things to help them in a non-pharmacological way. Be sure to watch the videos on Blackboard that discuss and so if a woman doesn't want to have an epidural right away or doesn't want to have an epidural at all, one alternative is to give IV push medication. Nubane is a very common narcotic that's given. It's usually given IV push to help a woman feel less of the effects of the uterine contractions. It's usually given for severe pain, so a woman would probably be complaining of a pain level of about 7. Ideally, it's best to give this once the person has started the second phase of labor and once the contractions are in a very regular pattern. But sometimes we do give it in the first phase of labor. The dosage is 10 to 20 milligrams. We give that IV push over about 3 minutes. You want to give that during a contraction when there is the least amount of blood flow going to the fetus. Okay. One of the biggest side effects is the effect on the fetus and also on the newborn if she delivers too soon. And we'll be talking about that in just a second. Okay, because the transfer of the nubane is very rapid and somewhat variable depending on how many contractions she's having, you have to really always be worried about the fetus and the newborn. The main side effect that you're going to see in the fetus is bradycardia and decreased variability. So those will probably decrease very shortly after you administer the IV push medication, and for a while you are going to just watch that. All right, but then if it lasts too long, you are going to intervene. If the woman is given the nubane and then delivers within a short period of time, then the baby can be born with some respiratory depression. Again, bradycardia, apnea, cyanosis, hypotonia, and decreased APGARs. So you have to be concerned about giving nubane when a woman is in labor, and then you have to be concerned about the baby after the delivery. So during labor, you are going to have that baby on continuous monitoring, and you will most likely see a decrease in variability. And this is pretty common because the nubane depresses the neurologic system, not only of the mother, but of the fetus. And you're going to let that go on for a little time, but after about an hour, you might be a little concerned about, is something else going on there? So you're going to perform fetal scalp stimulation, which is to insert your fingers into the vagina and to stimulate the fetal head. What should happen when you do that is you wake up the baby, that bothers the baby, and it causes an acceleration. This can also be accomplished with acoustic vibration to the abdomen. After delivery, you're concerned because the baby may still be depressed. And you might ask yourself, well, how close to the time of delivery should I be concerned if she received Nubain? And if it's been within a half hour, for sure, I would be concerned about that. Realizing that the peak of Nubain is probably about a half hour, and the half-life of Nubain is about 5 hours. So when this baby's born, you're going to stimulate the baby to breathe just like you would a normal newborn, but the baby might need a little oxygen. And if the baby is not breathing or breathing very slowly, you would have to back the baby and take the vital signs continuously or probably every couple of minutes. So besides IV push medication, you might be giving local or general anesthesia. Local anesthesia to the perineal area is given when you perform episiotomy or you are repairing a laceration. The pudendal is a form of a local anesthesia, but it's a wider area than that used with just the local tissue for an episiotomy. The spinal and epidural, we're going to cover that in just a second. And general anesthesia is only given for emergency situations. And the key here is to get her under and get that baby out as quickly as possible. So if your patient is planning on getting an epidural, you want to be sure to explain the procedure to them and to also get the consent form signed. The anesthesiologist will come in and talk more about the risk factors and a little bit more what to expect and answer their questions. So the epidural goes into the epidural space. And it blocks from approximately just below the breast line down to the upper legs. It's very important that you get your patient in the correct position. This patient is sitting up, hunched over, and we typically call this that her back is out and in a C position. Some anesthesiologists would prefer the patient to be lying on their side, but they would also have to be in this C flexed position of the vertebrae. During the epidural, it's really important that you monitor the patient. So you're going to be continuously monitoring their blood pressure during the procedure. And you're also going to be checking the fetal heart rate during the procedure. Now, as you look at this patient, you see that there are no belts on the patient for the fetal monitoring. So it's important that the nurse, probably with her hand, hold the ultrasound so that she can hear the baby's heartbeat during the procedure. So the first thing they're going to do on the top left picture here is they're going to prep the abdomen. This is the anesthesiologist doing that. And then they are going to give a little local, and that's that little wheel that you see on the back. That's probably the most painful part of the epidural. In the far left corner, you can see that the epidural needle is in place. Usually the patient feels a lot of pressure at that time. And in the far right picture here, the anesthesiologist is about to thread the epidural catheter in through the needle. So what's going to happen is that the catheter will stay in place and the needle will come out. And here you can see how it's going in through L3, L4, going into the epidural space, and then being threaded up through the epidural space. After the procedure is done, the anesthesiologist is going to tape it to the woman's back. This is very important that it's secure. And also the anesthesiologist is going to put it in the IV pump. And it is the anesthesiologist's responsibility to regulate the pump and to give all boluses of the medication. So if you need to make a change besides a patient-controlled bolus, if the patient needs more of a bolus or the rate needs to be changed, you need to call the anesthesiologist to come and do that. So as you look at this patient's back and you see that it wasn't in there very deeply, you can see that it could easily come out. So when this person is turning from right to left, it's very important that they don't slide or glide and dislodge the dressing in the catheter. Okay, so nurses have to be responsible for doing certain things before and after the epidural. Probably the most important decision is when to have it inserted. That all depends on the woman's birth plan, how quickly you anticipate the labor going, and the availability of the anesthesiologist. So there has to be an order from the obstetrician for that. You have to notify the anesthesiologist that your patient's ready. Lots of times there is a lot of coordination between your patient and other patients who are in need of the anesthesiologist, either those in labor or those having a C-section. You need to get the informed consent, and it's extremely important that the patient get an IV bolus of a liter of lactated ringers or D5-LR prior to the insertion. So that whole liter should go in within a short period of time, and probably ideally within a half hour to an hour. If the patient received a liter of fluid over 4 hours, I would probably give her at least 500 milliliters in about 15 minutes. You want to take the baseline blood pressure and fetal heart tones so that you can compare those after she receives the epidural. After the epidural, you're going to take her vital signs every 3 to 5 minutes for 15 minutes. You're going to check the O2 stats, continuously monitor the fetal heart rate and variability, and monitor the effects of the epidural. Is it working? Remembering that it's probably going to take about 15 minutes to be fully in effect, and that with every contraction, the pain will get a little bit better with every single one. Eventually, you're going to have to catheterize her because she will be unable to avoid, and you're going to have to give her a lot of teaching on not only the speed at which she could expect the pain relief, but also about what she can and cannot do while she has an epidural, and that's like turning without help, getting up and ambulating. And lastly, you want to encourage her to rest and sleep. She's probably exhausted at this point, and the best thing for her is to really, really relax. Let that uterus do all the hard work and every other part of her body be completely relaxed. So, what's the role of the nurse in managing the patient's pain in labor? Well, one of the things that you want to do is to identify and discuss what they desire as their primary pain relief method on admission. This is very important that you get an idea as to what they would like. Some patient will say, I'm having an epidural. Others will say, I'm going all natural. Some people might say, well, I'd like to do it naturally. Some people might say, I'm not too sure. So then you would have to give them more information. You might want to talk with them about what did they learn in their childbirth classes, or what type of breathing or relaxation methods have they practiced. Whatever it is, you want to demonstrate your willingness to follow the plan. And you also want to help support people who are there to encourage them and to help them to follow the plan. You might have to use everything in your toolbox to help a patient to have a, quote, natural delivery. So you're going to use the breathing, the relaxation, the guided imagery, the massage, and anything else that you can think that might help this lady to cope with the pain better. Be supportive, encouraging, and positive. And at some point, you might have to go to plan B. And so you will bring up the suggestion of possibly some IV push med or an epidural. But that's usually later on during the labor process.